virtual scientific platform called Diabetes Connect Live. Diabetes Connect Live is our unique scientific initiative in which we are able to bring key opinion leaders from across India in diabetes and related cardiometabolic specialties to discuss about latest development and the best practices with regards to diabetes and related comorbid conditions. And we are quite privileged to have an eminent diabetologist from Chennai, Padma Shri Dr. V. Mohan, as moderator for today's session. So I will be moderator as well as speaker for today's program. Along with Dr. V. Mohan, it's a matter of great pride for us to have an iconic cardiologist from Mumbai, Dr. Jamshed Dalal, with us in this particular program. So it's my duty to first formally welcome both the faculties, Dr. V. Mohan and Dr. Jamshed Dalal, to our virtual scientific platform. So I welcome Dr. V. Mohan and Dr. Jamshed Dalal.
Thank you.
Thank you so much.
Thank you. Coming to today's agenda, we have a very interesting topics lined up. First, Dr. V. Mohan will be speaking on cardiorenal protection in diabetes. Where are we heading? So this is an rapidly evolving area in diabetes with regards to the newer agents. So first, Dr. V. Mohan will be speaking on this particular aspect. Followed by that, Dr. Jamshed Dalal will be speaking on the sweet spot heart failure prevention with SGLT2 inhibitor. And after both the talks are over, we will be having a joint Q&A session, which will be moderated by Dr. V. Mohan. So my request to all the attendees, you can start posting your question in the comment box once the lecture starts. And in the end, Dr. V. Mohan will be taking up all the questions along with Dr. Jamshed. So with this, I would like to introduce and invite Dr. V. Mohan. So I believe Dr. B. Mohan does not need any introduction to the attendees, but as a courtesy, I would like to briefly introduce Sir to all the audience members. So Dr. B. Mohan is the chairman at Dr. Mohan's Diabetes Specialty Center and president Madras Diabetes Research Foundation, Chennai. His major research interests include epidemiology of diabetes and its complication, genomics of diabetes, and fibrocalculus pancreatic diabetes. Conferred fellowship from all the four Royal College of Physicians, also
Thank
all
you.
three science.
That's enough. Most of the know me, and anyway, it's there. So in the interest of time, probably was.
Sure, sir. Sure, sir. So, in 2012, he received prestigious Padma Shri from Government of India. So, with this, I would like to invite Dr. B. Mohan to virtual podium to share his idea about today's agenda and to start his first talk. So, virtual podium is all yours, Dr. B. Mohan.
This slide can go off. I'll bring my slide up and then.
Yes, sir. Yes.
I hope it is seen.
Yes, sir. We can see, and it is a slideshow. Yes.
Thank you, Dr. Nishan Dalal, and I'd like to thank you as well as INTAS. It's always a pleasure to work with your company because it's unbiased scientific program, CME. It's a double pleasure for me because I have a good friend and a very distinguished colleague, one of the iconic figures, as you yourself said, the legendary Dr. Jamshed Dalal from Mumbai. I'll introduce him briefly after my talk. So it's nice to have, you can see how cardiology and diabetology are merging nowadays because there's so, we always knew that diabetes is a cardiovascular risk equivalent. But with the drugs now for diabetes also able to help the heart, a true amalgamation of cardiology and diabetology has taken place. And that's what I think would be the scientific feast for today. So the title of my presentation is Cardiorenal Protection in Diabetes, Where Are We Heading? And I work with numerous companies, so I have to declare my conflict of interest, although this is not based on any particular molecule as such, this particular talk of mine. It's a more general view of most of the anti-diabetic drugs, including several of the SGLT2 drugs. And many of these companies actually make various competing brands of SGLT. Now, let me start with this particular slide so that we all come on the same page. The word diabetes beyond a metabolic disease brings back memories of my undergraduate days where we didn't have a proper definition for diabetes, but we used to say it's a metabolic cum vascular disease. And we've been saying this now for the last 40, 50 years. So it's not that only now we know it's a vascular disease, not just a glucose disease, but that it actually affects the entire vasculature. And therefore, it's definitely beyond a metabolic disease. And at least these four, if there are many more, but nephropathy or kidney disease, eye disease or retinopathy, cardiovascular disease, and neuropathy can be considered four of these complications. Although there are many other systems which can get affected. We just tell you, it's not just glucose alone that you read on a glucometer or in a lab, which is diabetes. Now, the other point which I'd like to say is that at any given point of time, the CV outcomes in people with diabetes has remained higher than in those without diabetes. For example, if you look at these are people in light green is the or light blue is the one in showing people with diabetes, and the dark blue is the one who are non-diabetic people. You can see that even in 1998 and 2014, the incidence of or the death from any cause as well as from cardiovascular disease has always remained higher in people with diabetes. And this has great relevance to a paper which we just published hardly 4 or 5 days ago, very important paper about which I will talk a little bit, where we had the opportunity to compare death rates both due to cardiovascular disease as well as all-cause mortality in people with and without diabetes, not just from India but from 21 countries as part of the PURE study. And my daughter was actually the first author in that paper, and I was the joint first author with her. So I will show you that particular study in a minute. But the point is that if you look at any period of time, death rates due to diabetes have remained quite high, and CV deaths also, as you can see here. Now, the good thing is that at least in the West, we can say that if you look at acute myocardial infarction, and probably I'd like Dr. Dalal later on to comment about this, is that if you look at 1990 to 2010, it's only a 20-year period, you can see how the acute myocardial infarction has actually started coming down from where it was there to say 150 per 10,000 adult population with diabetes. It's come down to almost half or less than half. Whereas strokes have come down a little bit, amputations have come down, but look at end-stage renal disease. It has not come down that much. Hyperglycemic crisis, by which you mean ketoacidosis, hyperosmolar coma, has come down significantly. That's a different scale altogether. That's not so common. The deaths due to that were never very high, but even that has come down by 50%. So what really has not improved that much is end-stage renal disease. It's still got a long way to go. And when you're talking about this is Ed Gregg, one of my good friends, who used to be at CDC Atlanta. Nowadays, he spends more time at the Imperial College in London, one of the best cardiovascular epidemiologists in general. And this is his paper in New England Journal 6 years ago. So this is the point, to say that acute myocardial infarction is coming down. But remember, this is only in the developed countries. In developing countries, we are nowhere near there, as my paper will show. So with that, let me come to this particular paper. This is published online on October 15, 2020. The title of the paper is Contrasting Associations Between Diabetes and Cardiovascular Mortality Rates in Low, Middle and High Income Countries. This is based on 143,000 patients, not patients, individuals, participants from 21 countries in the PURE study. I'm sure many of you will know what the PURE study is. PURE stands for Prospective Urban Rural Epidemiological Study, and this is the mastermind of my very close friend, Dr. Salim Yusuf, with whom I've been collaborating now for 20 years. In fact, PURE started in India. It first started in St. John's Medical College because he was an admin at St. John's, so he started there. Within few months to a year, 4 other centers in India were added. So we thought it's going to be a pan-India study. But then in typical Salim Yusuf style, he never stops thinking big. So from there, he went to other countries in Asia. China was added, and then one by one, countries were added. The numbers went up. Initially, we had about 30 or 40,000 people from India. The numbers are for this particular study, it's 143,000 from 21 countries. Today, we are up to another 4 or 5 countries have been added. The number of participants has now crossed 200,000, 250,000. So it's fair to say that the PURE study is the largest epidemiological study ever done by humanity. There's no other study in medicine which is bigger than this. Also, it is continuing now. And the beauty of this is these 153,000 people were followed for 15 years. So we started Pure around 2000, 2001. Now we are at 2020. So we have almost 15 years of follow-up on every individual who is in Pure, and that is why you can see the list of authors from different countries who have contributed to this. So Pure, once Pure publishes something, it's kind of a game-changing kind of a paper. And of course, my daughter and I work very closely with this, and many of the diabetes studies in Pure are actually we take the lead in that. There's so much to do in Pure. Pure is not just diabetes, cardiovascular. Now we are going to cancers. We are even studying COVID now. Anything you name it, climate change to anything you name, Pure has it. More than 100 kind of good papers have already come out from Pure. So Pure is a massive study. And just to show you only 2-3 slides from that, which are 2-3 figures from that. Now this is, I'd like to walk you through this slide. Now what this shows you is the major CVD, okay, is shown here. All-cause mortality is shown here, and in C is the cardiovascular mortality. Let me run you through this. Now, it is not surprising that even in high-income countries, if you look at the overall CVD event rates, they are higher in people with diabetes, and so is it in middle-income countries, and so is it in low-income countries. So if you compare the non-diabetic people in high-income countries with the diabetics in the high-income countries, it is higher. And similarly, in the low-income country and in the middle and the low-income countries. But look at the actual values. If you look at even among the CVD rates, even among the non-diabetic people, there is an increase in the low-income countries, and among diabetics also there is an increase. So while this relationship is still maintained between diabetes and non-diabetic people having more of CVD, the actual event rates are higher in low-income countries. And that is what this paper is all about, that the West is making progress, but or the high-income countries making progress, but the low-income countries we are still far behind. Now, if you look at all-cause mortality, this includes death in diabetic patients and non-diabetic due to any cause. Now, you will see that in the high-income countries, only a slight increase in the all-cause mortality, 2.9 per 1,000 person years to 4.2, just marginally. It used to be much higher in the diabetic patient, in the diabetic individuals, as I showed you in the earlier slide. But now you can see the differences have narrowed. That means the diabetics and non-diabetics are becoming more equal now. In the middle-income countries, little bit more difference. Here, in low-income countries, there is a much more of a difference. But that's not the point I want you to notice. Look at the all-cause mortality in the non-diabetic population in the low-income countries. It is 11.4. In the diabetic population in the high-income countries, it is only 4.2. So even among the non-diabetic subjects in low-income countries like India, the all-cause mortality is more than 2 times, almost 3 times higher than those with diabetes in the high-income countries. So that shows how much they have progressed in their treatment and how far behind we are in India and in other developing countries. And now if you look at, this is all-cause mortality. Now if you look at cardiovascular mortality, again the same story. You can see cardiovascular mortality has gone down significantly. This is because the all-cause mortality includes even cancers and certain things which we are not yet found cures for. But look at the cardiovascular mortality in the high-income countries. It is 0.4 in the non-diabetic population. It's so low. And even among diabetics, it is only 1 per 1,000. In the middle-income countries, slightly higher. Look at the low-income countries. Even among the non-diabetic subjects, it is 3 per 1,000, which is 3 times higher than the diabetics in the high-income countries. So you can see how badly we are doing. If you compare with the diabetics, it's actually almost 5 or 6 times higher, the death rates due to CVD in the low-income countries compared to the high-income countries. So that's the whole message of this paper. that while in the West and in the rich countries, due to insurance, due to available free care, and so many other factors, whereas here people have to pay out of pocket and so on, we are still far behind with respect to mortality in the low income countries. Now, another point which came out very interesting was this. What we did was we looked at all these three, the major CVD, the model, the major CVD, all cause mortality, and CV mortality. What is model one is the after just adjustment for age, sex, ethnicity, and the center which is studied. In model two, what we did was we adjusted for the behavioral factors, physical activity, smoking, BMI, hypertension, and so on. In model C, what we did was we adjusted for anti-diabetic drugs, anti-hypertensive drugs, glucose lowering drugs, cholesterol lowering drugs, and aspirin. So all the things that you can use for treatment. I want to show you, there's a lot of data here. I don't want to get confused. I'll just focus your attention on one or two. Look at all-cause mortality. Look at CV mortality. Now, this is comparing diabetics with non-diabetics in these high income, middle income, low income. Very important point. Concentrate on this. Look at all-cause mortality. In the high income countries, all-cause mortality is 36% higher in the diabetics compared to the non-diabetics if you just look at across the board. But the moment you start adjusting for physical activity, smoking, and now when you adjust for the aspirin, the BP lowering drug, cholesterol lowering drug, and for diabetes, it has disappeared. It has disappeared, become 0.99, which means there is no significant difference in the mortality of the diabetics and the non-diabetics in the high income countries. If you look at CV mortality, there is a difference from 84% increase, it comes down to 63% increase. Look at the middle income countries also, 64% increase coming down to 14% increase. So once you adjust for those who are taking statins, BP drugs, the sugar tablets, anti-diabetic drugs, and so on, there is a considerable decrease. That means if these people get adequate treatment, they will also become like a non-diabetic person. Now come to the low-income countries. Okay, the all-cause mortality is 33% higher before you do any adjustments. After you do all the adjustments, after you adjust for statin, BP drugs, diabetic drugs, and so on, it is 40%. If anything, it has gone up. That means treatment is not adequate. After controlling for the treatment, there is no improvement at all. That means they are either not getting the drugs, they are not taking the drugs, compliance is very poor, or they are underdosed. Maybe they are taking 5 milligram of statin, okay, or they are taking diabetic drugs, one drug when they are taking 2-3 drugs. That's the point. And look at this again. If you look at the CV mortality also, no difference even after adjustment for all these factors. What is the conclusion that we made? The conclusion of this paper was a very, very important paper, very, very hard-hitting paper. So CVD rates, all-cause mortality and CV mortality were markedly higher among those with diabetes in low-income countries compared to middle-income and high-income countries, with mortality risk remaining unchanged even after adjustment for risk factors and treatments. And therefore, our message is to all governments and to everyone is there is an urgent need to improve access to care to those with diabetes in low-income countries to reduce excess mortality rates, particularly among those in the poorer strata of society. Within the low-income countries, we looked at, based on the wealth index, we looked at the richer people, middle income, and the low-income group within the LIC. And there we found it's the poor in the LIC who really do badly. The rich somehow are able to escape. They are beginning to behave more like the Western world because they can afford anything. They can go to private care. They can afford for the treatment and so on. So this is a very important message in relation to today's talk. And this is the first time that I'm presenting this particular data. Now, patients with diabetes are increased risk of complications such as CV disease, heart failure, and CKD. That is very well known because I don't have to tell this audience that NAFLD is more, that heart disease, atherosclerotic cardiovascular disease is more, heart failure is more, and of course CKD. You don't even have to say 50% of patients with type 2 diabetes have CKD, and also heart failure is very common. Now the point is that these three are interrelated. It's not that the heart is separate, kidney is separate, diabetes is separate. They all blend into each other as shown in this slide. Because if you have a reduced cardiac output, if the cardiac output comes down, the kidney gets affected, isn't it? And if you have a kidney problem, then due to fluid retention, heart failure can come. And if you have NAFLD with all the insulin resistance and so on, that can affect the heart, can affect the kidney. And they are all related to each other. So it's not as if one is independent of the other. In fact, the whole is greater than the sum of its parts. So if you add all these risk factors together and you put them all together, the whole becomes actually greater than the sum of its parts. Now, coming to kidney failure, now while the other kidney, if you look over the years, there is no increase in, say, glomerulonephritis or cystic kidney and so on. But look at the two which are increasing. It is hypertension and diabetes. And within that, you can see it's the diabetes which is the leading cause of kidney failure, not only in US but also in India. We have data from India also to show from our nephrologists that if you look at end-stage renal disease, almost 40 to 45% of everybody who undergoes dialysis or transplantation, it is due to diabetes. So diabetes is the commonest cause of kidney failure. Now, therefore, to manage diabetes, it's not enough if you just control glucose. You have to reduce the blood pressure, LDL, and the glucose. And I'm not showing you a paper here for lack of time, but in one of my papers, which I published in the year 2013, we showed that if the blood pressure, the LDL, and the glucose are well controlled, people with type 2 diabetes can live for 50 or more years with type 2 diabetes. That became a classic paper. I don't think the paper has been repeated again by any other group in the world. And that is the reason why they gave me the Harold-Rifkin Award 2 years ago. So it's simple. The message is very simple. And the STENO2 study showed that. In a randomized clinical trial, they showed that just 80 patients, they got a New England Journal paper. So if you control the lipids, LDL and glucose, you're going to do well. But that's where the clinical inertia comes, and we don't reach the targets, and we don't push hard enough. And that's what all these CMEs are all for. Having said that, is there any evidence that the newer agents that we use in the treatment of diabetes after sulfonylureas and metformin, many drugs have come? Do they have any cardiorenal benefit? And this, all came after the CVOT trials were mandated by the US FDA after rosiglitazone had a problem and was temporarily withdrawn also in the year 2007. So over the last 13 years, there have been so many CVOT or cardiovascular outcome trials about which I'm sure Dr. Dalal will be talking later. If we just run through, I'm not going to give you an overview of all the CVOT trials, but just tell you that the DPP4 inhibitors, one of the newer agents, there have been 4 drugs in that. We take saxagliptin, alogliptin, sitagliptin, and linagliptin. They have been well controlled for this one CVOT trials, and in all of them, what happened was they were shown to be neutral. Look at the hazards ratio: 1.96, 0.98, 1.02. None of them have shown superiority, except with saxagliptin, which increased the heart failure a little bit. Beyond that, there were no bad effects due to the DPP4s. So suffice to say that DPP4s are excellent drugs, can be given in to an 80, 85-year-old person without any risk, and therefore they are very safe. But they don't have any benefit of protecting the heart or the kidney. That has not been shown with these drugs. If you look at the GLP-1 receptor analogs, there are several classes of that, as you know: lixisenatide, liraglutide, exenatide, semaglutide, albiglutide, and so on. And the first oral semaglutide is also now going to come to India. Now, if you look at that, they went a step further as compared to DPP4s, which did not show any direct benefit with respect to the heart. Liraglutide, for example, there was a 13% reduction in the 3-point MACE and a 28% reduction in CV death just on this. People who are taking this particular drug, and these were statistically significant. Some of the others did not reach statistical significance, although there was suggestion of an improvement, but they did not reach statistical significance. But with liraglutide, there was a significant improvement. With semaglutide, again, there was a significant improvement: 26% reduction, 22% reduction with albiglutide, and they reached statistical significance. Although with CV death, we had improvement only with liraglutide and with oral semaglutide. And with stroke also, there was some improvement in some particular studies. But suffice to say that these drugs, the GLP-1 receptor analogs, have not only shown that they are cardiovascular safe, but also that they may have a protective effect, which may not be a class effect, but some drugs in this class like liraglutide and semaglutide are actually showing a beneficial effect. Now, if you look at the third class of drugs, that is the SGLT2 drugs, these drugs really created history. And it was actually empagliflozin, which is the first to show that in the EMPEROR outcome trial, where there was a 38% reduction in the hazards ratio for CV death. In fact, the CV death, this has been perhaps the only drug which has shown that, and we'll show it to you in a minute. Now, what was very interesting is this circled portion, the dotted lines you see here, the separation of the graphs between the placebo and the empagliflozin arm started very, very early. Now, this is 6 months, this is 3 months, this is 1 month. So, within a month, we began to see separation of the graphs. So, something happens very early, and what that is, I'm sure Dr. Dalal will talk to you why these drugs are behaving like miracle drugs. They're almost being used like a cardiovascular drug now. Now, if you look at all the gliflozins, the SGLT2 drugs, and we have 4 of them listed here: empagliflozin, Cana, DAPA, and in credence for Cana again. These are 3 major drugs which are used in India. With EMPA, there was a reduction in the 3-point MACE, CV death and heart failure, and all-cause death. So this is a drug which had improvements in 4 of these. With Cana, with 3-point MACE, and with CV death, if heart failure is hospital heart failure is included, you got the thing. But CV death alone, they did not get it. And in dapagliflozin again, they did not see the improvement in CV death. But when heart failure is included, it gets improved. In the credence trial, on the other hand, there was an improvement in the 3-point MACE, in the CV death, and in CV death and heart failure. But the main thing, the main effect in all these is the improvement in the hospitalisation of heart failure. You can see 35% relative risk reduction, 33%, 27%, 39%. So as far as heart failure is concerned, across the board, this appears to be almost a class effect, although in one of the subsequent drugs with another molecule, they didn't quite make this improvement was not seen. But it's fair to say that at least 3 of these drugs improve or prevent heart failure, which is a very important thing. And this is actually the next analysis done was they divided patients into those who already had atherosclerotic cardiovascular disease and those who had only the risk factors for cardiovascular disease. And they found that if you had atherosclerotic cardiovascular disease, then the improvement was a little bit more. And in the multiple risk factor group also, there was no deterioration or anything, but obviously the effects were a little less. Now, if you do a meta-analysis of all the SGLT2, the 4 trials, the final conclusion is that SGLT2s protect against CVD and death in diverse subsets of patients with type 2 diabetes, regardless of the CVD history. So I'm not going to go into this. Dr. Dalal probably talk about this, but you can see that irrespective of whether they had which of the sub units you looked at, the MACE or cardiovascular death, and especially for heart failure, they seem to be across the board. There was an improvement. Now, if you take all these classes of drugs together, the SGLT2, the GLP-1 receptor analog, basal insulin, alpha glucose inhibitor, DPP-4 inhibitor, and TZD, except for the sabertini where saxagliptin increased heart failure, DPP-4 inhibitors were very neutral as far as the heart is concerned. And as far as the GLP-1 receptor analogs, I told you in LEADER, there was a suggestion of an improvement. And as far as the SGLT2 drugs are concerned, clearly, irrespective of which drug you use, heart failure effects are quite marked. And of course, I don't have to tell this audience that there are certain drugs you should not even consider using, even if you suspect heart failure. And the TZD group comes under that, because both in the proactive trial as well as in the record trial, there was a significant increase in heart failure due to TZD. And that's not the only side effect of TZD. You have 10 other side effects of TZD, with the result that TZDs are hardly used nowadays in the treatment of diabetes. I think less than 1% of people now use TZDs. The drug is almost gone. So just to make the point that the SGLT2, which seems to have the best effect as far as heart failure is concerned. This particular trial has made a lot of news because it's dapagliflozin, where they use it in the treatment of heart failure with reduced ejection fraction with or without diabetes. So DAPA was compared with the standard of care, and the primary endpoint was hospitalization, heart failure, or CV death. And what they found was that if you look at the results, the uh, the CV death was reduced, and cardiovascular the primary composite outcome was also improved. Cardiovascular death was reduced, and then this is the most important point about this particular paper. They looked at people with diabetes and without diabetes and found the same effect. Now remember, dapagliflozin is an anti-diabetic drug, and here you're using it in people without diabetes, and you're still seeing improvement in heart failure. So I'm sure Dr. Dalal will say you cannot call DAPA anymore or the SGLT2 a diabetic drug when it's a heart failure drug. We claim, it as our own drug. I won't be surprised if he says that, and I will, gladly given to that, because if it can be benefit others, why not? Is the question. Now coming to, before I end, about the kidney part. Now another twist in the tail was that it's not just heart which these drugs seem to improve, but also the kidney. So if you look at the kidney progression, we have the EMPEROR trial, Canvas trial, Declare, and Credence. Again, across the board, there seems to be an improvement. To me, this was a big surprise, because what I thought was, okay, it may improve the heart, but it's working on the kidney in a diabetic person, and therefore it's definitely going to damage the kidney because you're driving the kidney. Surprise, surprise, no, I was wrong. It's actually improving the kidney, and it's slowing down the kidney progression. And this is the data again from the from the EMPEROR trial, where if you look at the progression of renal failure, the black is the placebo arm. This is the fall of the eGFR over time, over 192 weeks. And compared to that, you can see that when you use empagliflozin, it is actually steadying it out. You can see that there's no fall at all. It seems to magically protect the kidney from going into renal failure. So if you have somebody who has heart failure or somebody who has kidney problem, these are drugs to choose if there are no other complications. And in the Credence trial, this is again shown that if you look at the primary composite outcome or the renal specific outcome, there was a significant improvement. And now again, if you look at the SGLT2s, a meta-analysis of 4 of the trials, and look at which aspect of the kidney it improved. If you look at dialysis, transplantation, or death, like your 3-point maze, you look at the 3-point kidney outcomes, it does improve. If you look at going into end-stage kidney disease, that also improves. Then if you look at creatinine doubling time, that also it improves. You look at acute kidney injury, that also it improves. You look at reversal of albuminuria, that also it improves. So almost every aspect of the kidney seems to be improved by the SGLT2. So again, the nephrologists now take over and they say, no, this is not Dr. Dalal's drug alone. This is our drug. We believe in it because it's going to help the kidney. And now trials are being done in people without diabetes to see whether it helps the kidney in those situations as well. And this is the DAPA-CKD study, again to look at the results. And to cut a long story short, both the primary outcome as well as the renal specific outcome all improved after using this particular drug. And again, if you look at just a story for the DAPA heart study, you look at the DAPA kidney study, whether you have diabetes or don't have diabetes, the improvement is there. If anything, in people without diabetes, it was more, a 50% reduction in the hazards ratios compared to a 36% reduction in those with diabetes. So something is happening. These kind of drugs almost miraculously are coming out. So with that, pari passu, or vis-a-vis these results, are we seeing also change in guidelines? Are people reacting to that? Indeed, yes, because we know now that it's not just glucose alone that you look at when you treat diabetes. First of all, look at patient characteristics. Then you decide A1C targets, and then you agree on a management plan and so on. But then you also see the presence or absence of other conditions, comorbidities. For example, this is the ADA EASD guidelines consensus report. It came out in 2019, where they clearly say that if atherosclerotic cardiovascular disease predominates, then either a GLP-1 receptor analog or an SGLT2 can be seen based on the trials which came out. And then if heart failure or CKD is the first presenting or the important consideration, then SGLT2s come out as a clear winner, because none of the other drugs actually have a beneficial effects on these two conditions. And then ADA 2020 further, kind of clarified this by further laying down guidelines as when atherosclerotic cardiovascular disease predominates, what you do, and then if the heart failure or CKD, again you can see the SGLT2s coming up prominently there. ACE 2020 even went a step further and said that if you have a risk of atherosclerotic cardiovascular disease and you have uncontrolled diabetes, you can even consider as monotherapy. As the first step, you can consider SGLT2s. So no longer you have to first give metformin and then wait and so on. If the A1C is less than 7.5, straight away give one drug, that is SGLT2. ACE has already, American College of Clinical Endocrinologists have already said this in the year 2020, and these guidelines may change. And of course, if it's between 7.5 to 9, then you give a double drug, and this double drug can be metformin along with, and again SGLT2 you can see comes right on top there. The 2019 ESC guidelines on diabetes and pre-diabetes have also been published, and what they are saying is also similar, that in drug naive patients, if the risk of atherosclerosis is very high or CV risk is very high, SGLT2s have now been promoted as the first drug. Or you can also, and if it's absent, then you start with metformin. So gone are the days when every diabetic patient first give metformin, and then if it doesn't work, or if as the next drug consider something else. They're radically changing that and saying even in a newly diagnosed patient, the risk of CV is very high. Straight away go for your SGLT2 or GLP-1 receptor analog, and only in the absence of that, metformin becomes the first drug. And so these guidelines are constantly evolving. So I'm going to end here by saying that if it's an adult patient that has more than one of the following characteristics, that is either heart failure or atherosclerotic cardiovascular disease or diabetic kidney disease or a high risk for cardiovascular disease, then according to these guidelines, along with the lifestyle and also control of diabetes, blood pressure, lipids, which I told you is very important, consider starting an SGLT2 inhibitor or a GLP-1 receptor analog. After discussing with the patient, of course, cost considerations are there, and then of course you can go to the other drugs. So I'm going to thank you and stop here, and my job now is to next introduce Dr. Dalal and ask him to talk. Do we have an intro slide to share? Yeah. So it's a great pleasure for me now to introduce my good friend, Dr. Jamshed Dalal, who is the Director of Cardiac Sciences at the Kokila Bell Hospital, Mumbai. He is such a senior person with over 40 years of experience in the field of cardiology. If anybody has not heard of Dr. Dalal, I think you better do your homework and better start reading up about him, because he's a legend and he's one of the last words in cardiology. He's been awarded so many awards in his lifetime that I'm not going to spend too much time reading out all that. And I think it's a great privilege for me to share this dais with Dr. Dalal and also request him to talk on the next topic, which is the sweet spot, heart failure prevention with SGLT2 inhibitors. So over to Dr. Dalal.
Thank you very much indeed, Dr. Mohan. Just get my slides going. Right. So I'm going to talk, Dr. Mohan's of course taken us through a vast, I hope you can see my slides.
Yes, sir, yes, it was it.
Dr. Mohan's already gone through the whole spectrum of the importance of SGLT2 inhibitors. He's mentioned about heart failure and CKD. What I'm going to go into is two of the more recent trials related to diabetes, SGLT2 and heart failure, the DAPA heart failure trial and the EMPEROR heart failure trial, because both of these trials not only looked at the effect of SGLT2 on patients with diabetes, but also those without diabetes. And therefore, clearly, as he has mentioned, we are now moving away from the concept of it being a diabetic drug with cardiovascular benefits to really a cardiac and a nephro drug with probably some effect on sugar as well. Now, in spite of so much work being done on SGLT2 inhibitors, we still do not know exactly how it works. I mean, miraculous drug, and of course, why miracles happen, we don't know. And that's why probably we don't know how SGLT2 actually works. There are many mechanisms which has been postulated, including some direct effects on the metabolic aspect of the heart, effects on the kidneys, and you can see a whole variety of things. But I think given time, we will soon get to know the exact mechanism. As Dr. Mohan mentioned, these drugs were actually not looked for as cardiac drugs. They were simply looking for safety effects of these drugs, and very fortunate for us that FDA mandated looking for safety of cardiovascular disease, because from that came this whole bunch of drugs which have been so beneficial for cardiac, and now, of course, recently found also to be extremely beneficial for kidneys. If I look at the earlier trials, the DECLARE-TIMI trial, that was a trial which actually had multiple risk factors for CVD and established cardiovascular disease, and we're not looking for predominantly patients with heart failure. But clearly, what the earlier trial of DECLARE-TIMI showed is that you had a reduction of heart failure hospitalization and a reduction of cardiovascular death. And this was seen predominantly with heart failure with reduced ejection fraction. And in this subset of patients, heart failure without reduced ejection fraction wasn't seen. There's a lot of work going on with SGLT2 and heart failure with preserved ejection fraction, and we all need to look further for that data. And not only did it help simply in hospitalization, but it also reduced all-cause mortality. As you know, there are very few drugs which actually benefit all-cause mortality to, and have this drug to do that in patients with cardiovascular disease was a significant benefit. Of course, the most important recent trial looking specifically at heart failure and more importantly at patients with and without diabetes was the DAPA heart failure trial, a large trial of nearly 5,000 patients in the New York Heart Association class 2 or 4, up to 4, ejection fraction less than 40%, which is usually the accepted norm for a reduced ejection fraction. Interestingly, as you can see, there were more patients without diabetes than with diabetes, but you can say virtually equal. Another interesting thing was almost a quarter of them were Asians, and therefore the data can be well interpolated to the Indian population as well. As you can see, as usual for most of these trials, the patients are usually class 2 to class 3. Class 4 patients are too sick, they often die before the trial ends, and therefore were very minimal in this group. If you look at the other factors, you can see that the mean ejection fraction was 31%. If we look at the cardiovascular death and worsening of heart failure, there's a very significant reduction of 26%. And you can see the p-value with so many zeros in it, suggesting that is a highly significant benefit of SGLT2. If you look at the separate components, because sometimes what happens is that when you have too many components, one component predominates and makes the primary endpoint positive, and that sort of skews the primary endpoint. But if you break the primary endpoints and look at worsening for heart failure, again, extremely significant. If you look at cardiovascular death independently, less significant than heart failure, but still reaching significance. So both independent endpoints were very effective. And then it's important also to look at the pre-specified subgroups, because does it benefit everybody or are there specific groups in which you'd see benefit? And clearly, as you can see down the line, age, gender, race, nothing seems to matter, prior hospitalization. Very important, I would like to also point out, as you can see on the right side, ischemic or non-ischemic cardiomyopathies or heart failures equally benefit, because it's often asked that would the SGLT2 benefit only if you have ischemic heart disease and only if you've got atherosclerotic disease? No, it benefits both the groups. I think that's important to remember, because we see a lot of non-ischemic cardiomyopathies also postpartum, and now recently, of course, post-chemotherapy induced cardiomyopathies. And I think that SGLT2s will be equally beneficial here. And there is work going on whether SGLT2 can be used as prevention of chemotherapy induced cardiomyopathy. So those will be very much more interesting data on SGLT2s. Now, important is that so far we've always thought that we need to use these drugs for patients with diabetes, which is why it was predominantly used, because it was started off as a diabetic drug. But now, if you look out here, you can see the graphs are equally beneficial whether you have diabetes or no diabetes in terms of the full primary outcome of CV death, hospitalization for heart failure, or urgent heart failure visit. So clearly, it does not matter if you have diabetes or not. And that completely changes the perspective. Because now, if a patient comes to me and is non diabetic, I do not have to consider or think about using SGLT2 because he's not a diabetic. I know from this study that my non-diabetic patient with heart failure will have equal benefit. If you look at worsening of heart failure events, again, trying to break down the individual events of the primary endpoint, diabetic versus non-diabetic, both equally and significantly effective. If you look at cardiovascular death by diabetic status, again, more effective with type 2 diabetes, but not little less so with non-diabetes in terms of cardiovascular death. If you look at all-cause death, again, significant both in terms of diabetic and non-diabetic. You can see a wider spread with a diabetic patient than with a non-diabetic patient. Again, the question of patients who are diabetic or non-diabetic and whose ejection fractions are very low, less than 25%, compared to those whose ejection fractions are not so bad, about 35%. I think it's important because there's a lot of concern about what should you do with patients who are, say, between 40% and 50%, or 40% and 55%, because clearly that's a group which has not been well investigated. Because we usually say reduced ejection fraction when the heart function is less than 40%, and we say normal when it's more than 55, but a large number of our patients are in between. Some of them may be transiting from poor to better, and some of them may be going downhill from normal to poor. And what do we do with this group of patients? Also important. What this study shows is that the patient's quality of life improves irrespective of whether they are in ejection fraction 25%, 35%, or 40%. So there is no worry about choosing only patients with borderline or reduced ejection fraction. Kidney function has been spoken about already by Dr. Mohan, but you can see that whether you have diabetes or no diabetes, the benefit of kidney function is again very good. And I think, in my opinion, the nephrologist should be even more happy than the cardiologist, because at least cardiologists have another 4 or 5 drugs which benefit heart failure survival. So we've got now an additional drug in addition to about 3 or 4 drugs that we already had. But I think for the nephrologist, this is a fascinating drug, because really, what could you offer these patients with kidney problems? They would go on dialysis, they would go into kidney dysfunction, they would go into renal transplant. Now, for the first time, I think they have a drug which can actually prevent this from happening, prevent worsening. If you remember Dr. Mohan's slide, hemodialysis reduction, transplantation reduction, progression to end-stage renal function reduction. So clearly, this is a very, very important drug for the nephrologist. And the benefit, again, whether you're a diabetic or a non-diabetic, is equal. So that's again very important that all nephrology patients will benefit from this drug. Again, we always seem to be caught too much about survival, but I think in patients, particularly with heart failure, the quality of life is very important. If you treat a patient with heart failure, see, when we used to treat a patient, say 20 years ago, it was such a sad situation if the patient came with heart failure. They'd be mostly bedridden, they'd be hardly able to walk, they could not even go to the toilet. Every few months, they would be hospitalized. Their life was miserable. In fact, they would be hoping to die. That is how bad their life was. So we should also look at quality of life as a very important aspect of treatment, not just survival. So if something shows no survival benefit, doesn't mean it's a useless drug. Quality of life is important. So when we talk so much about SGLT2 in terms of survival, we should also look at the improvement in quality of life. As you can see here, the deterioration in terms of quality of life or the improvement in quality of life, both in the non-diabetic and the diabetic patients, is very important and very marked. So I think it's a very important thing. Quality of life is very, very important in these patients with heart failure. If we look at the safety outcomes, and I think that's very important because there is a concern, and I think one of the reasons for the inertia of using SGLT2 is the side effects. They have been played up. We can ask Dr. Mohan in his practice how often he sees these problems in terms of urinary infection, genital infections, and ketoacidosis that can happen. So I think these are the things which concern people, and therefore people have been concerned about starting SGLT2, especially the non-diabetologist. As cardiologist, I've always been a bit anxious about starting these drugs because of the fact that, especially when we have diabetic patients, we don't see patients who are simple diabetics. These diabetic patients with heart failure will be on insulin, multiple other drugs. And I think to add another anti-diabetic drug like SGLT2, you have to look at the full picture of the patient. It's not just simply a question of looking at the heart failure, but I think therefore it's very important to have an endocrinologist and the cardiologist and the nephrologist now working together. I think it's very, very important that the three specialties work together for the maximum benefit to the patient. The good thing for a cardiologist is that it does not produce hypoglycemia. That's a major worry that we have when we treat our patients. And we know that by giving SGLT2, they won't get hypoglycemia, which will not precipitate angina or myocardial infarction. So clearly, you can see this benefit at all ages, which is also important because we should not deprive the elderly of SGLT2 simply because they are elderly. And I think, therefore, you should not say that these are drugs which should not be given. Of course, you should be more careful. Dr. Mohan's already shown this side, this remarkable improvement in kidney function. Again, on the left side, diabetic, on the right side, non-diabetic. As you can see from this slide, there's always a drop in terms of the creatinine clearance. But as you can see, once the creatinine clearance drops, it remains stable throughout, compared to those who are not on dapagliflozin, where the creatinine clearance continued to decline. So this is something which we need to clearly explain to our patients that yes, your creatinine will go up, because all physicians know as soon as the creatinine goes up a bit, the patient gets extremely anxious and will not be willing to take your drug. So showing this diagram to them, showing the long-term benefits of on the kidney is very important, because the patient will look at the creatinine, get anxious and stop the drug. He may not tell you, but he may still stop the drug. So I think communication is extremely important if you want to prevent, if you want to have good adherence to the drug and prevent loss of compliance. So communication is vital. After the DAPA heart failure trial came in, the question was that is this related only to DAPA, or is this again a general SGLT2 class effect? As Dr. Mohan repeatedly mentioned, it's a class effect that we see. Now, will Emperor reduce, which is again a very well-controlled randomized phase 3 trial? Again, patients with ejection fraction less than 30%, large number of patients, 4,000, simple empagliflozin versus placebo, looking at multiple endpoints. One was the cardiac, which was the composite primary endpoint, and the second was recurrent heart failure hospitalization, and third, looking at the kidneys. So this is like the DAPA heart failure trial, looking at the same heart failure events, hospitalization events, and kidney events. So let's see how it compares to the DAPA heart failure trial. Now, if you look at some of the differences between the inclusion, if you look at the inclusion exclusion criteria of the Emperor trial, you can see that they've again chosen patients with ejection fraction less than 30% to ejection fraction less than 40%. But now when it happens is that when you have an ejection fraction of 40%, sometimes you're not sure whether the patient's in heart failure or not. So they included BNP. So when your heart failure, ejection fraction was more towards 40%, you had to document a high NT-proBNP in order to include the patient. The idea was to make sure that these were patients of genuine heart failure and not masquerading as heart failure. And again, if you look at the right-hand side, the exclusion criteria now, the GFR has been brought down to below 20. So now we got low deep down into the GFR. So anybody above GFR of 20 was included in the trial. So they took really sick patients, both in terms of cardiac and renal functions. Again, if you look at the baseline, happy to say that there is a significant group from Asia. So I think that helps us to give confidence for using in our patients. And again, you can see predominantly class 2 and class 3 as in DAPA. Again, the primary composite endpoint, the adjudicated CV death or hospitalization for heart failure, and you can see a very significant relative risk reduction of 25%. And if you look at the number to treat, it's only 19. So only 19 patients need to be treated. That's a very, very good number for NNT in terms of beneficial effects of the drug. So clearly, like DAPA heart failure, this clearly shows that the primary endpoint with empagliflozin in the subset of patients that they studied was extremely beneficial. Again, looking to see whether all patients benefit, you can run down the line: age, gender, race, baseline, BMI, baseline GFR. Again, GGFR more good, eGFR bad, doesn't matter. All patients benefit in terms of the primary endpoint. If you look at the other subgroups in terms of baseline, if you go down the line and look at mineralocorticoid steroid use, if yes or no, again benefit. ARNI, in the DAPA heart failure trial, about 10% of patients were on ARNI. In the Emperor trial, there were about 18% of patients in ARNI. And you can see that's a question which most people will ask, that if we have heart failure, should we use ARNI? Should we use SGLT2? Should we use one over the other? Should we use both? So we do not have all the patients on ARNI, but 10% in the DAPA group and about 18% in the Emperor group. And clearly you can see that whether the patients were on ARNI or not on ARNI, they're equally benefit. So the question of which to use and whether you can combine has clearly been answered. If we look at the secondary endpoints, which is the heart failure hospitalization first and recurrent, because recurrent hospitalization and heart failure is very important. Each time you get hospitalized, it pulls down your mortality and you're going to die sooner. So you have to prevent heart failure hospitalization, which is very, very important. And clearly, the secondary endpoint of looking at heart failure hospitalization or recurrent hospitalization is 30% relative risk reduction, which is quite significant. If you look at the composite renal endpoint, which is end-stage kidney disease or sustained profound decrease in eGFR, again, a very significant 50% relative risk reduction can be seen. So clearly, clear benefits, as with dapagliflozin, with the EMPEROR trial as well. I like this slide because this slide also shows exactly what the DAPA showed. You can see that in terms of eGFR reduction, as you can see, the immediate drop in the GFR, which is same as what we saw with the DAPA trial. So there'll always be a fall in GFR. It's something you must warn your patients who got border creatinine that the creatinine values will rise, the GFR will fall. But if you look at the purple line, it remains straight throughout. And you look at the ones not in SGLT2, you can see the downward going line. And you can see that the cutoff is around 60 weeks or so. So that's the period at which the kidney function will continue to deteriorate in patients who are not on SGLT2, while as it remains steady. So I think that this is a very important slide and a very important communication that we must do with all our patients with renal dysfunction. So put together, the EMPEROR-REDUCED trial was extremely efficacious. Primary endpoints significantly reduced, that is the adjudicated CV death and heart failure hospitalization. Secondary endpoint, first and recurrent heart failure hospitalization, and the kidney eGFR slope significantly benefit. So very positive trial in terms of primary and secondary endpoints. Again, as I mentioned, quality of life, significant benefit in terms of quality of life. And you can see very early benefit in terms of quality of life. Dr. Mohan mentioned to you about that, and I'm going to talk about that in a little while later as well, that the early benefit of these drugs is something you need to keep in mind. Because the reason we say that again and again is that you must start this treatment early. Why should you wait and wait and wait till the patient deteriorates? And they said, now I think maybe we should start SGLT2. That's not right. Start at the moment you see the patient with heart failure. So do not wait too long. The benefit is very soon, and that's the way you should treat these patients. If we were to compare the two, which I think is important since we have got two major trials, if you look at the ejection fraction, a little bit less in the EMPEROR-REDUCED compared to DAPA, not much, 27 versus 31. NT-proBNPs were higher in the EMPEROR, so the patients were more sick. If you look at the medicines, as I mentioned, ARNI 18% in EMPEROR, 10%. Rest of the drugs were all very well given, both the patients. You can see the diabetic group, of course, they had planned almost equal, both the groups, half in each diabetic and non-diabetic. So clearly, both the studies extremely well planned, extremely well executed. Now, of course, since you have two trials, you've got to have a meta-analysis. So as soon as the trial was published, the next day the meta-analysis were published, and this is a meta-analysis of these two trials. So clearly, because now what happens is instead of getting 4,000 patients, you've got 8,000 patient analysis. And if you look at the with diabetes and without diabetes, you can see Emperor DAPA equally effective, total subgroup equally effective. Without diabetes, again, both equally effective, total subgroup equally effective. So clearly, the meta-analysis, if you have one more trial, we can add that to the meta-analysis once it comes. So clearly, further benefit that you can see. If we look at the ones receiving ARNI and not, because I think that's a point which at least a lot of cardiologists are very interested in, can we give ARNI along with, clearly both the trials have used ARNI, overall percentage of use 10% versus 20, so significant number of patients, and you can see a very significant benefit in this whole group as well. This is a very recent trial, looking not a trial but a effect noticed on the complementary effects, and you can see from here that the two are very complementary. If you look at paradigm trial and the DAPA trial and the combined, then you can see that this is an additive benefit in terms of CV death, heart failure hospitalization, and all-cause death. So clearly the aim should be to start both these drugs and to give them as soon as possible. So I think this is the two things that we need to remember. Combine all the drugs which are beneficial. I know people will talk about cost, etc., but I think those are issues that we have to deal with whenever a patient can afford. I personally think that more than cost, it is the inertia of the doctor, which prevents patients from being on drugs. And if you look at the statistical, in terms of all-cause mortality and cardiovascular mortality, there has been a little bit of discussion on this point because Emperor-Reduced had less all-cause mortality and reduced cardiovascular death compared to the DAPA, but I would not get into this too much and say that one drug is better than the other. I think both are equally efficacious. There are different studies, different subsets of patients, so we should not get into this. Clearly, both drugs will produce benefit in terms of mortality, cardiovascular death as well. And if you look at the kidney outcomes of both of them, clearly both showed extremely good benefit. So there is virtually no doubt about that as well. So from a heart failure point of view, if you were to look at the drugs that we commonly use, let's look at ARNI, because I think now most people will agree that we don't have to go through the stages of AC inhibitors, ARBs, and then start ARNI. It's now clearly agreed that we should start ARNI irrespective of patients already being or not being on AC inhibitor. And if somebody is on AC inhibitor, then I think you should change them over to ARNI. ARNI, the problem is that there's no single dose. It has to be given twice a day. There's no single fixed dose, so you have to keep varying the dose, start small, grow big. The advantage is that with SGLT2 inhibitors, as you can see, it's a single dose. You don't have to change it. As somebody mentioned, that even for a cardiologist who doesn't want to think too much, it's very simple. Both the drugs have got one single dose, 10 milligrams. They have to give it once a day, and they do not have to have titration. So really, it doesn't require good thinking, which I think is great benefit to us. Once a day, one dose, 10 milligrams, no titration. Compared to the other drugs where you have to start small doses, keep titrating the doses, give them twice a day, watch the creatinine, watch the electrolytes, watch the blood pressure. None of these things are an issue with SGLT2, except, of course, the initial rise of creatinine. I do not want to underplay that initial rise of creatinine, because if you have a patient with a very border creatinine clearance, and you start SGLT2, yes, you can push the patient into problems. So you need to watch it. Clearly, I'm not suggesting that you should ignore that, because if the creatinine clearance begins to fall and you feel the patient's getting deteriorating, then you need to stop the SGLT2 inhibitors. Also, in situations where patients are sick, you need to stop the SGLT2 inhibitors, because in those situations, the patient may get worse. But again, if you look at this chart, you can see that, relatively speaking, it's a much more simpler drug to use. Some of the pearls of wisdom, as they say, in when not to use the drug. So you should not use in pregnant and breastfeeding women, because we don't have any information on that. It's important to realize that you should stop the drug when you're planning for surgery or the patient's hospitalized for severe illness, etc. So if a patient presents to us with heart failure or any other severe illness, if the patient is not on SGLT2, do not start SGLT2 at that time. You could start maybe pre-discharge. So that's the best time when the stressful part is over, patient is more stable. If the patient's already on SGLT2, you should stop the drug and then restart it later. But again, let's remember that it's important for us to restart the drug before the patient goes home. Because if you don't restart the drug, chances are the patient may not get the drug for many months later. And again, the question of ketoacidosis, I'll leave it to Dr. Mohan to explain how many of these patients have it, how big a problem there is. There has been a couple of reports suggesting that it is an issue, but I have no practical experience of that, and I think Dr. Mohan will be the best person to talk about this aspect of SGLT2. Again, if the patients are old, frail, volume depleted, or urinary infections, improper genital height, you need to be cautious about it. So do keep these things in mind. Simple as the drug may be, you always have to make sure that you don't produce harm. Now I want to talk about the DAPA-CKD trial, not because of the CKD part, which Dr. Mohan has already spoken to you. And clearly, again, the CKD trial showed the significant value. If you just take a glance up at the p-value, I can't even seem to count the number of zeros. There are, I think, 6, 7, 8 zeros out there, suggesting a very highly significant value. But of course, what the DAPA-CK did was also look at the heart failure as a secondary outcome. Why not? So like one more information on a different set of patients. And clearly, you can see here, again, very significant reduction of cardiovascular death, hospitalization for heart failure. So though this trial, the DAPA-CKD was predominantly for renal, they of course had a secondary endpoint of heart failure, again confirming the benefits. So it's good to have confirmation of your data by different trials. And again, very important, if you look at all-cause mortality in the DAPA-CKD, again, there are significant reduction. So clearly, a trial meant for kidney improvement showed great kidney improvement, but also heart failure benefit and also all-cause mortality benefit. Now, the whole problem is that we can have 100 lectures, talk about it, we can have 200 studies all showing positive, but yet we won't start the drug. And every time I used to talk about heart failure, I used to put up a slide. My first slide used to always be 50% death in 5 years. That's the standard slide that everybody who talks on heart failure puts up. But I think this should not be there anymore. That should not be our first slide. If that is our first slide, then we are doing something wrong. Look at this data, very recent published, and they took 20,000 patients less than 70 years old, and they looked at the survival if they were on drugs, and they were not even on SGLT2. They're simply looking at RAS blockers and beta blockers. And if the patients were on drug, the 5 year survival was 86%. And of those who survived, 78% did not require hospitalization. So clearly, the 50% death rate at 5 years is non patients who are not given drugs. And if you add to this SGLT2 inhibitors, you add to this ARNI, I think that our survival for 5 years should be very close to 95, 90, 95%, and absolutely no reason why not. It's the doctor's inertia which is creating a problem. Dr. Mohan mentioned also this very important point of the early effects. The effects are seen within a month. So, what does that suggest? That suggests that we need to start these drugs early. What we often do is we have a patient who comes with heart failure. He gets admitted to the hospital. You give him your diuretics, etc. Patient, of course, gets much better, and you discharge him without the optimal drugs. Then the patient goes home. He comes to the OPD. You may or may not remember to start the drugs. Patient will say, "I'm feeling very good." Doctor says, "Oh, you're good. Continue your medicines." Nobody at that point starts the drugs, and we well know right from our statin days that if you don't start a drug at the time of discharge, the chances of the patient starting the drug or being on the drug will be very much less. And again, more important, that early part, the 1 month period after heart failure hospitalization is the very vulnerable part. That's when you want to give maximum treatment. So, seeing the patient after 2, 3 weeks and starting treatment, you miss that vulnerable period. So, very, very crucial to start early. You can see from this trial as well with empagliflozin. Very early benefit, same 4 weeks benefit in terms of benefit. So, clearly, important fact to remember that early treatment is important. And this has been discussed, and I'll mention this because I saw this only a couple of days ago, that patients get benefits from each of these drugs surprisingly early, with improved outcomes in clinical trials appearing within few weeks. 4 drug classes are there. They all improve the health status, the LV size, the LV function, reduce hospitalization and even mortality. So after 30 days on quadruple treatment, a patient's relative risk of death drops by more than 3 quarters compared to patients not on these medications. So, if you have a patient with heart failure, diabetic or non diabetic, renal dysfunction, no renal dysfunction, it's our job to make sure that the patients are on all the optimal management treatment as early as possible, because you can see from here how much benefit these patients get. This has been shown clearly by Dr. Mohan again, that we now have this whole change of concept of treating patients, that we don't need to go through the whole the diabetic profile, diabetic drugs, and then change over to SGLT2. GLP-1 is not a subject of talk today, but GLP-1 predominantly is more beneficial for atherosclerotic vascular disease, where it is significantly benefit. The SGLT2 clearly much more benefit in terms of heart failure. Kidney benefits have been seen much more this SGLT2, but GLP-1 inhibitors also have some kidney benefits, so they are not to be left out. So I think, and we can also combine the two drugs, and we can discuss with Dr. Mohan about the combination of GLP-1 and SGLT2 in patients who got diabetes, heart failure, and kidney disease, and how beneficial that would be for all our patients. So I'd like to end by thanking you for listening to me, and I would like you to go with one particular point, which is to make sure that you start all your patients on all these drugs right as soon as possible, monitor them closely, and I think it is our duty to break this inertia and make sure that our patients live with a good quality of life for as long as possible. Thank you very much indeed.
Thank you, Dr. Dalal. That was a very clear presentation and very clear messages. We have some time for questions, and I think there are quite a few questions which have already come up. So let me see whether I can go to the top of the list. So I think the first one is from Dr. Dimbeshwar Das. I'll read the question. We can decide whether you can take it or I can take it. Would you explain the mechanisms proposed for SGLT2s? Would you explain the mechanism proposed for renal protection, even improvement in renal function? I'll probably take that, and you can also supplement. Well, we not always in medicine we know the answers or the mechanisms to everything. Metformin has been around for almost 60 years now, or more than 60 years. We still don't know how it works, but it works very well, and we don't care as long as it works very well. It's not the mechanism of action which is most important. There are many theories. You can say it's probably because it reduces blood pressure, reduces weight, reduces sugar. It might have direct effect on the kidney. It can have metabolic benefits. It can have many theories have been proposed, but neither for heart failure nor for the kidney improvement do we have one single mechanism saying this is the reason. Well, quite often it could be multifactorial, could be working at different points, and all of them could be contributing. And the mechanisms to study always takes time. First thing is to see whether it works or not. Now, how it is working in animal studies, you can do all kinds of experiments. In clinical situation, it's not so easy to find the exact mechanism of action of a particular benefit of a drug. What do you say, Dr. Dalal?
I perfectly agree with you. I think sometimes even when we think we know the effect of a drug, we may be knowing only the superficial effect of the drug and give it all the credit, but the action of the drug may be on something quite different from what we haven't thought of. But again, it's not possible to know the effect, especially in a clinical subject, as to, and many times the experimental studies don't always correlate with the clinical benefits. I think it's good enough to show that there is benefit of the drug. I think we need to show the benefit of the drug. We need to show it repeatedly to make sure it's not just a one-off thing, and the drug should be safe. I think safety is also paramount. So if
Right.
we can show benefit repeatedly and with safety, I think I'd be happy without knowing the mechanism of action.
That's what we really don't care if it really. Well, that's not science. We still try to find out. I'm sure there are people still working on the mechanisms, and we will generally come. It's useful to know. Now, if after 60 years, metformin really didn't work this way, somewhere, okay, it's nice to know. That's not going to change my treatment anyway. So, Dr. Nikki has some very kind comments about both of us saying, my honor to listen to two stalwarts. Thank you, Professor Nikki, is very kind of you from Amritsar. Then Dr. Dimbeshwar Das again. Do you recommend antiplatelet therapy for primary prevention CVD in all diabetics as shown in one of your slides presentation? That's addressed to me. If yes, which antiplatelet drug, aspirin, propofol, others your personal experience, sir? And then there is in view of more and more younger patient diagnosed diabetes, chance of all complete going to be much higher in younger times. What can we specifically do in a patient to prevent CV complete, keeping in mind limitation of a country? Oh, that's Dr. Basu. That's another one. Okay, first let me take Dr. Nimbeshwar. So, do you recommend antiplatelet therapy for primary prevention all diabetic patients? Now, not necessarily, Dr. Das, because if you have a 25-year-old, a 20-year-old patient coming with type 2 diabetes, very common now. We're getting 18-year-olds, 16-year-olds, 12-year-olds coming with type 2 diabetes. When do I start antiplatelet drug for him? Just because they have diabetes, they start next 50 years, they're going to take it. We know that these drugs can produce GI bleeds, they can have other side effects, and so on. So for primary prevention, it is not really recommended by any of the associations. Secondary prevention, there is no argument at all. You definitely have to treat. However, having said that, if you have if you do any kind of scoring, Framingham scoring, any other scoring, and you find that the risk factors are very high of developing an MI or having a CV event in the next 4 or 5 years, or if there is a strong family history of coronary artery disease or any cardiovascular disease, then that would make this patient very high risk. Or if there are multiple risk factors, patient has hypertension, dyslipidemia, diabetes, obesity, smoker, all kinds of things, then we would probably, give it a little earlier and probably for everyone. Otherwise, every patient who comes in with diabetes, type 2 diabetes, just diagnosed, 20 years old, okay, start aspirin. That is not something which I do. Choice between aspirin and clopidogrel, generally aspirin is more the first line to be used. If there's any intolerance or any other thing or fear of bleeding or anything, then clopidogrel will be what we use. What about Dr. Dalal? What would be your approach?
Yes, I think as we all know, we used to use aspirin routinely as a primary prevention for decades now. Started in USA, and in fact, even today, large number of Americans take primary prevention aspirin small dose. There are four recent trials which came out last year and year before, all clearly showed that yes, aspirin is good for primary prevention. It reduces cardiovascular events, but it produces bleeding, which actually is more than the benefit. So today, when we look at the net benefit bleeding versus the benefit is ischemia, it comes out that the net benefit is against the use of aspirin. And the recent recommendations by all societies is that aspirin should not be used as a routine for patients as a preventive measure in diabetes or no diabetes. As you correctly mentioned, in certain subset of diabetes, I think that clearly it should be used, but not generally over the board. I would personally think that it would be better to use statins in diabetes rather than aspirin because the net benefit is more in favor of statins. Again, aspirin or clopidogrel, there is no study looking at clopidogrel for primary prevention, so we don't know an answer. But now, suddenly, over the last couple of years, that cardiologists have become anti-aspirin in many dual antiplatelet therapy when we have to stop one antiplatelet. Now, invariably, aspirin is dropped and the clopidogrel is continued. So it's possible that you might use clopidogrel, but we do not know the answer to that. Dr. Mohan, I want to ask you a question. If you have a diabetic patient, uh, mostly I agree that you would start statins in most of them. Now, the question is that I was told that SGLT2 inhibitors reduce your chances of developing diabetes. I don't know how true that is, but that was mentioned by one of the big SGLT2 workers. So, therefore, we know that statins increase your chance of diabetes. Now, if you have SGLT2, which reduces your chance of diabetes plus cardiovascular and renal benefits, do you think it's a good to combine statin and SGLT2 as a sort of primary prevention? Is it at all possible to think of that?
For that, we need to do a trial. Anything that we assume has to be supported by a trial. So we cannot give a scientific answer until we have the trial. The hypothesis sometimes is wrong, sometimes is right. But irrespective of whether statin has this, just like you said, the benefit is less than the risk with the case of aspirin. Here's the other way around. The benefit is much more than the theoretical risk of it developing diabetes. We can't brush it aside. We can't say it will never happen. But is it a major cause? Certainly not. We have so many other causes for diabetes. We have obesity and physical inactivity and unhealthy diet, family history, stress, depression, even things like pollution and things like that coming in. They'll all be much higher in the list of a statin producing diabetes. In our own studies, in the CURE study, when we followed up, we're not done in CURE so far, but in CURE's, in our own Chennai-based epidemiological study, where we followed up the individuals 10 years before and then 10 to 15 years later to see whether what produces diabetes, incident diabetes, and so on. Statin was there, the suggestion was there, but it was not statistically significant. Which means it is not one of those causes. Among all the causes of diabetes, like steroid, you can add on statin. No, that will be far lower, and the benefits of it are so much more that I would say don't worry about the theoretical risk of diabetes. You exercise, you can reduce the risk of diabetes. So take the statin and exercise more. And then, as you said, SGLT2 could be not for primary prevention of diabetes, but as if you are in a diabetic patient, certainly the benefits of that in reducing the cardiovascular risk as well as reducing weight and reducing everything else, I don't think will aggravate. I have not seen statin aggravating the diabetes in a already diabetic person. Just if you give statin, sugar went out of control. Stop statin, it went down. All that you can dramatically see, even with some diuretics, you can see that with steroids, you can definitely see it. You can see with antidepressant drugs, you can see with so many other drugs. Statin will not come in that class. Maybe among all the things, yes, a slight increase in the sugar may be there. So I think the risks are very low compared to the benefits. Now, the other one is, I think it's directed to me, in the view of more and more younger patients, should we specifically prevent cardiovascular complications? I think Dr. Basu, you're absolutely right. It's the period of exposure. So somebody gets diabetes when they're 50 years old. The chances of them, developing, let's say, microvascular disease, kidney disease, eye disease, is rather minuscule because it takes 20-25 years. First of all, when you get it after 50, it's called mild age-related diabetes. Today, we know that in the sub-classification of type 2 diabetes, that will become the marked category or the mild age-related diabetes. So it's milder. They have better beta cell function. The risk factors are less. The genetic factors are less. That's why they got it when they're 50, 60 years old. So for them, by 65 to develop kidney-related diabetes is not going to happen. We also know that the younger you get diabetes, the more aggressive it is. So not only you have longer period, you get it at 20, you have to live for 40, 50 years now. And therefore, the period of exposure to diabetes is much more. Apart from that, it is a more aggressive type of diabetes. Genetic factors are more, the environmental factors are more. That is why you're getting the diabetes. And with it comes also the risk of complications. So the younger you get diabetes, the more aggressive we should be in keeping the sugars under control. It's also more difficult to treat. It's a more aggressive disease, therefore it's more aggressive to treat. And therefore, we should go all out in trying to prevent not only cardiovascular disease, but also the microvascular complications as well. So treating them early, I think, makes a good thing. Now, the next one is Dr. Ramraj, risk of fractures, genitourinary infection while using SGLT2. I think you also want to ask me that, Dr. Dalal. How common is the genitourinary infection? Well, we can't brush it away. We cannot say that urinary infection is not that common, I must say. There's a genital infection which is quite common. Both in males and females, genital infection is common. Now, what do we do when it comes? Sometimes we just skip it for 4 or 5 days and then use an antifungal and then better hygiene and so on. It goes away, and then next time when you take it, the body gets used to it, and then you don't get it. But there are about 5% to 10% of patients who get recurrent genital infection, and they simply don't like to take it. But the moment they take it, they are embarrassed and they don't want to take it. So in those patients, you simply have to avoid the drug. There is nothing else. It's like statin myopathy. If you get severe statin myopathy, even the smallest dose, what can you do? You use something else instead of the statin. You just can't use it. So there are a group of patients like that. Fractures with SGLT2 is very small. I would say fractures with pioglitazone is much more. It's very well documented, especially in women, especially upper limb fractures are very well documented. With the SGLT2s, whether they produce lower limb amputation, canagliflozin, one of the trials showed that, but the next trial did not show that. Today, it is not accepted as one of the important causes of amputation or lower limb fractures or anything like that. So I would say that is not high in the list. Genital infections, yes. Euglycemic ketosis also, you asked me, is it common? Well, if you are insulin dependent, if your C-peptide level is low, you must be a little careful about using these drugs because it can push you into ketoacidosis. I know that in Europe, DAPA is actually approved in type 1 patients. I don't know how they gave it. I am a little scared to use it because I've listened to many lectures on this in abroad, especially in US, where they use it. 5% of patients will develop DKA, the frank ketoacidosis and coma. They can develop. Now, 5% is too high for me. In a type 1 child, if I go and use this and then the child dies of ketoacidosis, I say, why the hell did I ever use it rather than using it? So I'm not brave enough to use it. I'm waiting for whenever a new drug comes, I'm one of the last to enter. And I'll be the first to leave it if there are any side effects. So that's my policy. Let's wait and watch, learn a little bit more. We will not be the first to enter into the water and plunge, so we'll wait and see if there's any side effect. I don't want my patients to be exposed to it. That is my philosophy. Do no harm. First thing, even if you don't do any good. So that's about that. Now, what to assess first in, so this is for you, Dr. La. What to assess first in type 2 patients with heart failure before prescribing SGLT2? Which one is more preferred in these cases? In other words, what tests would you do or something? Probably that's the question. What to assess first before prescribing SGLT2? That is, if they have heart failure, should you assess anything at all, or you can give it straight away?
See, when the patient has clear heart failure, I think that's easy. You have to start SGLT2, and heart failure remains a clinical diagnosis. It's not necessarily a echocardiography diagnosis. Heart failure predominantly is a clinical diagnosis with echo, etc., confirming your clinical diagnosis. But if you have a patient, and this has been discussed earlier, at what stage can you start the SGLT to prevent the patient from going into heart failure? Now, that is a little more tricky question, and especially because we do not know when heart failure actually begins. We don't have actual data on whether SGLT2 will benefit people with diastolic dysfunction or heart failure with preserved ejection fraction. We don't have data on that. But if you see evidence on echocardiography of longitudinal strain problems or evidence of early dysfunction of the left ventricle or the BNP is elevated, patient doesn't complain of anything, maybe just fatigue, that's all. There's no clinical evidence of heart failure, but patient complains of fatigue, BNP is elevated, patient's a diabetic. Yes, this patient may be going into heart failure. Should we start SGLT2 inhibitors on that? You may start, but again, there's no strong data to suggest that. If you see all our group of patients that they study class 2 to class 3 heart failure, majority not class 1 heart failure. So clearly we don't have enough data for the class 1 or the pre-heart failure stage. So I think in that situation, I would individualize the patient looking at his symptoms, BNP and echo findings, but
Probably
not
future
routine.
studies will look at that, and just
Yeah.
like now we're going to non-diabetics with heart failure and diabetics with kidney disease, probably people will start studying that. New trials will probably be done. Dr. Mahershi is asking a question: what should be done with patients on metformin plus DPP4 plus voglibose develops heart failure? Should we switch over to gliptin from gliptin to SGLT2, or should continue with DPP4? Dr. Mahesh, I think that has been answered well enough now. For heart failure, definitely SGLT2 would score. DPP4s are safe. You can use it in heart failure. It's not except unless it's AXA, then you would definitely stop it. Otherwise, they're safe. If you have sitagliptin, you can continue it. But SGLT2 is given for the treatment of heart failure and helps heart failure. So there's no question that if you can either change it or add it. It doesn't mean you cannot combine a DPP4 with the SGLT2 also. You can do that also. You also asked about combining Dalal, whether you combine SGLT2 with a GLP-1 receptor analog. Well, it's a very good combination, and I would say the one indication for that would be obesity. So for people who want to lose weight, if they are struggling to lose weight, if you use an SGLT2 along with GLP-1 receptor analog, of course, cost, you're not talking about cost and all here. We're just looking about whether scientifically you can combine them. Absolutely no problem in combining these two, and they will definitely lead to a greater weight loss than use of either drugs alone. And they both have benefits on the heart. SGLT2 will also then protect the kidney. So I think it's an excellent combination. And now we have even weekly preparations of the GLP-1. So even that can be used. And oral molecules of GLPs are going to come. So I think we are in exciting times. Then Dr. Meenakshi Sundaram has asked, just like ACE inhibitors, where we have to be careful with those with serum creatinine more than 2, is there a cutoff for SGLT2 inhibitors? I think the cut point today is eGFR of 45, but up to 30 now trials are going on, and so maybe up to 30 you can use it. Below 30 eGFR, I think it is still contraindicated. You should not use that. Do you agree?
Yeah, the Emperor heart failure went down to below 30 also. They did include patients. Below 20, they excluded. The question is, of course, as I always say, that you have to be careful for these patients, just like you are with ACE inhibitors. Though I mentioned and showed the diagram saying that yes, creatinine clearance will fall, do not take it lightly, because some patients may be precipitated into renal, dialysis and various things. So watch them closely, and especially when you're using along with other drugs like RAS blockers, which might also have an effect on creatinine clearance, and you're combining these two drugs, be even more careful. So when you're borderline renal function, please be careful when you start these drugs, especially when you start them in a combination, and do a very keep a close eye. So
I agree entirely. Dr. Meenakshi Sundaram has got a good question. Why stroke risk is said to be increased with some of the SGLT2s? Do we have similar concerns with GLP-1 receptor analog? I'll also answer, and I'll also ask you to answer. Well, it is not really increased as an increase. So it's not that the heart failure and the CVD went this way and stroke went completely that way. And that too, it's molecule specific. Not in all molecules and all trials have shown that. But it's fair to say that maybe the benefit that you expect for the heart you may not see with the kidney, although with the brain, with the stroke. Although in some molecules, even there was a suggestion that even with the stroke that there was some improvement. So these could be because they're not specifically designed to be stroke specific studies, and stroke is also more difficult to quantify. Either have a stroke or don't have a stroke. It's not like in the heart where you can measure. So you can measure the ejection fraction, or you can measure heart failure better than you can measure stroke. We don't even have good markers like pro BNP or BNP and so on for stroke. So it's not that if you have this you will get stroke, or your risk of stroke is so much that a warning against stroke has to be given. The benefit for that may not be with that particular drug. That would be my take on that. What would be your take, Doctor?
yes, I think clearly the stroke benefit is not anywhere near close to heart failure benefit and kidney benefit. Again, we know that GLP-1 has more benefit in terms of atherosclerotic vascular disease. So if you have a stroke which is atherovascular with carotid plaques, etc., that you may get more benefit with GLP-1 compared to SGLT2, where you don't have such benefit in terms of plaque modification, etc. So I think that if you had more atherosclerotic problems, either cardiac or stroke, GLP would be a more useful drug to use. And if you had more heart failure issues and more renal issues, then SGLT2 would be the
That's what
one.
the guidelines actually say. Yeah, correct. Then the next one is Dr. Prasanna. What is your view on pioglitazone and CV safety? I use them quite frequently in my practice. So, Prasanna, I'm not asking you not to use the drug, and definitely, in the proactive trial, some CV benefit was shown. But the problem is in the proactive trial, also as we showed in the slides, there was an increased risk of heart failure. About that, there is no doubt at all. It's one of those confirmed things that this talk is all about heart failure. So, in the terms of heart failure, even as a doubt of heart failure or in the presence of heart failure, pioglitazone is completely contraindicated. There is no doubt about it. Now, whether it will produce some other benefit on the heart, but it may produce heart failure. Well, there are drugs that produce all the benefits now. We have got SGLT2s that reduce heart failure, reduce the chance of atherosclerotic cardiovascular disease. Every aspect of the heart, it is improving. So, why should I use a drug which will produce heart failure, but it may improve other things? And therefore, I don't I'm not saying it's not use the drug, but there is always that risk. And heart failure is not the only risk. Remember, fractures are very well known, fluid overload is known, macular edema is known. This risk of bladder cancer, they say now maybe it's not there, but the small risk is always there. Weight gain. Who wants weight gain? Everyone wants to lose weight, and here is a drug which will massively increase your weight. I've seen people put on 18, 20 kilos after pioglitazone. So with all that, I think the drug has lost its charm right now. In patients with DKD and on large dose of insulin, adding SGLT to dose of insulin reduced precipitously. Any such economy? Of course, Dr. Rohit Mahajan, absolutely, no doubt about it. Even yesterday, I had a patient who came back to me, after some time, he was taking some 220 units of insulin and he was not taking SGLT2. In fact, he wasn't taking any oral drugs at all. So I added metformin and SGLT2, and I said, you know what? I think you're just taking too much insulin. So off the cuff, from 220, I made it 130. He said, Doc, I'll go into keto. I said, nothing's going to happen. You just see what happens. And his sugar improved, his weight reduced, his dose came down 130. And yesterday, when he came back to me for review, I further reduced the insulin dose. And I said, you know what? 132 is too much. Let's try 80 now. And then I'll further reduce the dose. So dramatically, I've had patients who've gone off insulin after taking SGLT2. So that definitely happens. Then, are there any data on new onset patient and non-diabetic SGLT2, whether reduced or should reduce? I don't know what the question is. New onset diabetes, whether it's reduced by SGLT2. We have to do the trial. Obviously, you have to do a pre-diabetic trial, as has been done with metformin, as been done Acarbose, and some trials on this one has also been done. DPP-4 inhibitors have been done. We have to do the trial and see. I wouldn't be surprised if it doesn't work. Although whether we should prescribe it for all pre-diabetics, that is I think lifestyle works eminently well. 58% reduction in DPP with lifestyle compared to 31% with metformin. So lifestyle is the king there. SGLT2 drug with metformin with basal insulin better than Lantus once a day, equally good as 3 times basal insulin is better to postpone. Well, Dr. Chandramohan, I think it's individualized. We cannot, talk about these things. In a given patient, we have to study that and see. And this for you. How about combining ARNI and SGLT2 in the case of heart failure together? You already answered that, but you can say that.
Yes, and definitely combine. Each one is equally beneficial, and when given together, they have a synergistic effect. So therefore, you should try and combine both together. Again, when patients got CKD, be careful because there will be a reduction of glomerular filtration rate in the beginning when you start the two drugs. In patients who are very borderline, it may be wise to start one drug first and then see the response and then add the other drug rather than starting both in combination. So I think you do need to be careful. But my personal feeling is that if you got diabetes and you got renal dysfunction, there's more evidence of benefit of SGLT2. So I would use that as the first drug. If it was a patient who's say hypertensive plus heart failure, I think obviously ARNI would be a preferred choice because you want to control hypertension as well. So I think you can individualize, but I would combine the two. And I think there's definite evidence to say that you can combine the two, and you can see from both the trials. So one was 10% and one was 18% use of ARNI. Whether they were on ARNI or not, both groups benefited. So addition of ARNI is better.
Next question, Arni is over. Can SGLT2 be prescribed, Dr. Prafulla Dixit? That's to me. Can SGLT2 be prescribed normal BMI type 2 patients? There is no contraindication. Just like we use metformin also in normal weight patients. So see the weight, just like the A1C, we say the higher the A1C, the more the fault. Similarly, if you have a lot of weight to lose, you lose a lot of weight with the SGLT2. If you don't have weight to lose, the body will take care of that, and it will give you the other benefits of the glucose lowering and the other benefits that you get. And if you have, let us say, a slightly leaner person whom you are suspecting heart failure or a high CV risk, why wouldn't you use? So just because you don't have obesity, it's not a contraindication for using SGLT2. Then Dr. Shastri wants to know, dear sir, do you have evidence for primary prevention of clopidogrel? So that's for you.
There's no evidence of primary prevention use for clopidogrel. Secondly, with the recent guidelines suggesting that we should not even use aspirin for primary prevention, I think clearly we should not use clopidogrel. It's in fact more powerful antiplatelet agent, and you'll probably get more bleeding. So clearly, unless very specific situations, as Dr. Mohan mentioned, diabetic, high family risk, a high CV risk, then you may consider using it. And if aspirin is not possible to use because of, say, GI problems, one may think. But routine use of clopidogrel for primary prevention of heart disease, no.
Clear answer. Dr. Rajesh Agarwal, how about Ramogliflozin or Remo? What he means Remogliflozin. Seeing the data looks similar. Your opinion? We have done some studies, Rajesh, and so Remo is for those who cannot afford the costlier molecules. In India, we always have a teneligliptin coming in as a gliptin and as Remogliflozin coming in. I have also used it, and it does work. I cannot say that it doesn't work. But if you're talking about hard endpoints, you're talking about CVOT trials and so on, we just don't have the evidence. So we must accept that also. So you cannot compare them with another class which has taken a 5-year or 6-year, CVOT trial and come out with evidence which we are able to show versus the Remo which is hardly used in the rest of the world. But having said that, there are many people in India where cost is a very big factor. So, and it doesn't seem to have any major side effects or anything like that. So, if you want to use drugs like that, which are less expensive, by all means we can use it. Any interaction with statin and SGLT2 resulting in increased rhabdomyolysis? Don't think
No.
so. It's
In
not.
fact, most of these heart failure patients were on statins, large number, and there was clearly no indication to suggest any toxicity of statins if the and SGLT2. So I don't think there's any such evidence.
Dr. Nair, what's the level of LDL we should try to achieve in a diabetic? How to use SGLT and diuretics in patients moderate to severe CKD? So LDL in a diabetic, what is your recommendation? Target.
Uh, well, it depends on what cardiovascular risk the diabetic patient is in. If the patient's diabetic with no cardiovascular events, nothing, then even less than 100 or less than 70 would be adequate. If, however, suppose the patient's a diabetic and has had a myocardial infarction or an angioplasty done, then I would go below, even as present recommendation is 55 of LDL. And if the patient has had recurrent events, like he's had two angioplasties, one bypass surgery, is a diabetic and falls into the very high risk or the extreme high risk group, the present recommendation of ESC is below 45 for these multiple events, so-called very high-risk patients. In fact, the most recent guidelines of the Indian Lipid Association is less than 35. So if you look at it, it's going down and down and down. And especially with the availability of PCSK9 inhibitors, you can easily bring it down to below 35. So I think it's not just the diabetes, it's the cardiovascular risk or the recurrent events. The one which you have to be most worried about are the ones with recurrent cardiovascular events in spite of being on statins. So if you have a patient whose LDL is say 60 or 70 and he has an infarct and another infarct, spite of being 70, then obviously that 70 also is too high for him, and then you aim for below 55.
It has to be individual. The answers. Dr. Sinha, what is the cutoff value of pro BNP when you say it's suggestive of heart failure? Do you have a normal value for
Yeah,
pro?
there are different values depending on age specificity, renal dysfunction, etc. As you can see from the trial, which the Emperor heart failure trial, which you can see, when the heart function is borderline, they wanted a BNP of more than 2,500. Whereas if the LDL, if the BNP was, if the ejection fraction was less than 25%, then the value had to be much lower. So I think BNP is a fluctuating value. It depends on the patient's age, renal function, etc. So clearly, don't go by one single value for these patients. If they're dehydrated, over volume, so everything will fluctuate the BNP values.
Then how do you manage a case of adventitial calcification without major intraluminal blocks? I think he's talking about diffuse calcification.
I think he's talking about CT angio with calcification. Now, CT angio calcification has now become a very important parameter. For example, the question of which patients would you give statin as primary prevention? There's a lot of fight about primary prevention with statins because of the so-called anxiety of statins that is there. So one of the ways in which you can decide is to look at the CT calcium score. And if you got a CT calcium score which is raised, then you should be on statins definitely. So CT calcium scoring is now becoming one of the tools to decide your risk factors for the future, just like you have so many other risk factor charts and things. So clearly, if you have CT calcium score increase, it suggests that you should be more on preventive medicines, both health, lifestyle, and as well as statins.
I think I'll take the last question from Dr. Sunil Sirsikar. Is it necessary to do C-peptide before putting a patient on SGLT2 in a lean type 2 patient? Well, it's not necessary to do a C-peptide, Dr. Sunil Sirsikar, because it's not a test which is easily available. It is also not a test which is cheap, and therefore I cannot in a guideline say every Indian diabetic should do, a lean person should do C-peptide. But if you come to a specialist center like ours, we do C-peptide fairly regularly. And the reason for that I'll tell you, not to start SGLT2, but in a lean patient with type 2 diabetes, we have recently, as you may know, we have recently classified type 2 diabetes into 4 types. The first is the lean type called as the SID variety, or the severe insulin deficient variety. The second variety is the severely insulin resistant variety, or the IROD variety, the insulin resistant obese diabetes, the IROD variety. The other one is lean insulin deficient. Here's obese and insulin resistant. Both are opposite. Both are opposite to each other. Then we have identified for the first time in the world literature a type which is called as TIRDD, that is combined insulin resistant and deficiency. The Scandinavian paper which is published in this group, they do not have this variety at all. In India, it is common to have both the deficiency as well as the resistance. And the fourth one is a mild age-related diabetes or the MAR. So we have these 4 types. So suppose somebody comes above 50 years of age, straight away MAR, you don't even have to do any test. But suppose a young person comes who is a little lean, it could be SID, which is a severe insulin deficient variety. It could also be a form fruit of type 1, which we call as LADA, or latent autoimmune diabetes of adults. And these people very rapidly progress to insulin, and within 6 months to 1 year, they may develop ketosis. So their C-peptide will be extremely low. Being one, a research center, and B, being a very academic kind of an institution. If our patients come to us, majority of them we do C-peptide, because that also helps us to classify, to publish these papers, we have to teach the rest of the world what to do with the patient. We have such a large database, over 500,000 patients in our electronic records, that we have an opportunity to learn all this. But again, if a patient cannot afford it, then we don't do it. Or sometimes we do it free or as part of research. But to answer the question, does everybody have to do it? No, you don't have to do it. You look at other parameters, look at the A1C, look at their body weight, look at other parameters, and you know clearly that this is not a highly resistant type of a patient. They won't have acanthosis nigricans, they will not have the features of dyslipidemia, they may not have all that. These are the patients who usually need a secretagogue. They usually do better with a sulfonylurea or with a load of some insulin given early, or to DPP-4 inhibitors. Whereas the obese category, they do much better on the SGLT2, metformin, that kind of a category. So even looking at the body weight, looking at the age, looking at the HbA1c, you will get some idea as to how to treat this patient. We're trying to develop an app whereby we put in all these characteristics, and probably the computer can suggest that this drug is probably better for this patient. We haven't quite got there yet, but we are almost there. And that is where the the test like C-peptide or doing HOMA beta or HOMA IR will help you. I'm not suggesting that everybody should do it, but as a researcher, I would love to do these things, but that is how I develop my own science. So therefore, we do that. So it's not necessary for you to do. Certainly, to start SGLT2, you don't have to do C-peptide to do that. C-peptide is usually done to see whether they need insulin. If it's below a certain level, no tablet will work. And these are people who need insulin. Now, on the other hand, somebody may come looking a little lean, but the C-peptide will be very good and it will be deceptive. That he's actually producing a lot of insulin. And therefore, we'll say, oh, this guy doesn't need insulin at all. The C-peptide is so good. That's where we use the C-peptide. Now, I know we have gone clearly 15 minutes more than the scheduled time for us, but I hope it has not been a waste, and I hope the audience has really enjoyed it. I myself have learned a lot. I always learn a lot from Dr. Dalal. So therefore, I'd like to thank Dr. Jamshed Dalal for very clear exposition, very unbiased views that he has given. And I will now hand over to Dr. Nishant Dalal to wind this up.
Thank you very much, Dr. Mohan. So it was truly an intriguing scientific feast that we witnessed today with two legendary faculties. As we all know, cardiorenal protection is a very rapidly evolving area, and I'm sure this session did a great job in making sense of all those rapidly evolving data and connecting the dots in such a way that clinicians can use them in their day-to-day practice. As I think Dr. Jamshed Dalal has also mentioned, is the clinical inertia with regards to some of those new agents. So I hope this session did a wonderful job in solving some of those the puzzling issues. So my thanks to Dr. Jamshed for a lucid presentation with a clear take-home messages. My sincere thanks to Dr. B. Mohan for a very comprehensive take on cardiorenal protection and also excellent moderation of today's event. My heartfelt thanks to all the attendees who have joined us from various parts of India. We had 923 viewers for today's meeting, so it was a truly wonderful meeting. And my thanks to all the viewers who have joined in for your wholehearted participation.
Thank
So
you.
thank you once again.
So much.
Thank you,
Thank you, Dr.
thank you, Mohan.
Dr.
Bye.
Dalal and to Intas, and look forward to more such meetings in the future. It's a real academic piece. Right? The
Thank
team
you.
of cardiologists and diabetologists and like
Right, cross specialty, right, sir. So thank you, Dr. Mohan and Dr. Jamshed Dalal, from the core of my heart for wonderful deliberation.
Thank you.
Thank you.